So, good evening, Professor Israel. Thank you for your time and for being here at the 37th Turing Cardiology Days. It's a pleasure for us.
Oh, my pleasure also.
So, the first question is how do you see the evolution of the ICD implantation and selection of the patient over the past years, and in particular in the context of a new and different heart failure management and with a different optimized and improved medical therapy?
Very good. 3 questions. Number 1, the implantation of defibrillators over the last 3 decades is getting more and more easy. It's an absolute standard procedure, and I remember the very first years where there were general anesthesia and lots of experts and ICD testing, ventricular fibrillation, induction, all this. This has all gone. Today it's usually in conscious sedation. It's if it's a single chamber ICD, it's a 20 minutes procedure through the cephalic vein to make sure that the ICD lead will stay stable over time. So implantation has much improved, is standard, and I think very easy with pretty much to 0 complications. That is number 1. Number 2, the indication today is, I would say, still difficult, because primary prevention means we need to prevent something that is unexpected, like sudden cardiac death is always unexpected. The only thing that we have learned is that in general, patients with severe heart failure with reduced ejection fraction obviously benefit the most. However, not everybody with a severe ejection fraction reduction benefits. Many patients with a mildly reduced ejection fraction would have benefited, but we didn't know. And all the other ways that we tried to predict sudden cardiac death from many electrophysiological standards, methods, they were all pretty much disappointing. Even the latest studies, anything else but ejection fraction at the moment, did not show very much prediction of sudden cardiac death. So the echo and ejection fraction 35 is still used. Now, one of the things that I would like to point out is that today we have much better drugs for heart failure treatment than we had in other decades, much better, and that is good for our patients. And that means that our patients with severe heart failure survive significantly longer than they used to. And that makes the ICD even much more important than it used to be, because the ICD plays a role only, let's say, in maybe 3% of patients per year. So if patients die usually from progression of heart failure within 1 or 2 years, only 3 to 6% of patients do benefit from the ICD. Now today, if patients survive 10 to 12 years with good drugs, and still 2% or 2.5% of patients would have sudden cardiac death, that means 10 times 2.5, 25 to 30% of patients may have an advantage by the ICD. And that is something that is, with good medical treatment, first, I think, not clear to everybody.
I find your position is brilliant. But the second question, you have already said something about that, that ventricular ejection fraction as the cornerstone to candidate someone to a DICD implantation. Do you think we have to move towards more integrative and multimodal risk assessment? And if you think so, what kind of assessment would you think would be better and integrate, like, I don't know, imaging or an electrophysiological study? I don't know.
Yeah, I think we still have to consider what we should try to do. And I always like mostly simple solutions. So yes, there are brilliant things like 3-dimensional MRI reconstruction of scar border zones, tunnels, and whatever. There's a combination of electrophysiology and MRI, which is all brilliant, very, very good, but very complex, very difficult to understand, and no randomized trials on any of these yet. So I think that is important, but I'm much more a fan of simple things. So one of the things that is usually not done today is the maybe most invasive diagnostic method. It's taking patient's history. So if you add, for example, just a history of syncope to poor ejection fraction, the chance that this patient will need the ICD is dramatically higher. There has been an old analysis in the Israel ICD registry that if you have not only severe heart failure, ejection fraction below 35, but also a syncope of likely arrhythmogenic origin, then you have a fourfold chance that you will need the ICD. So that is something very, very simple. Patient history, syncope, and mostly syncope during activity, syncope during supine body position. These will be very, very likely arrhythmogenic, and if survived, this is a good candidate. The other thing that is not used so much today is also simple. It's the 12-lead EKG. And we can see sometimes not only the ejection fraction, poor, mildly reduced, whatever, but also, for example, a Q wave, a wide and deep Q wave, of course, is a big scar and may have an impact for re-entry tachycardia. Similar to QRS complex duration, the wider the QRS complex, the slower conduction, the more likely VT. So these would be, I think, in 2026, and that is very funny, very, very old and very simple and very low-tech solutions, how we could improve our prediction of the patients who will most likely benefit from the ICD.
Thank you very much. Thank you very much. The last question as well. After the Botox intervention, I'm going to ask you something about the new device programming improvement of the last year. We think that the prolonged detection time interval and the ATP first strategies are good strategies to avoid shock therapy and reshaped during the year the risk-benefit ratio of the ICD therapy. What do you think about that? And if you think so, there are some suggestions or tips for clinical practice?
Yeah, it's a very good question. So I'm a big fan of ATP because it may prevent shocks. And what we know of shocks, of course, any shock will increase the adrenaline level. And if in patients with a severe cardiomyopathy, adrenaline levels are high, this can result in electrical storm. And I've seen patients who had 6 shocks, all were effective, terminated VTVF, but within 3 heartbeats, the next VTVF started. And typically after 6 shocks, the ICD declares the patient is dead. And it will not survive him anymore. So there is a problem with electrical storm and immediate reinitiation of ventricular fibrillation. And at the center of this, definitely there is adrenaline and sympathetic tone. So if we can prevent shocks by anti-tachycardia pacing, this will likely have a benefit in this situation. And I've also seen patients who have been running around with a ventricular tachycardia for 1 week or 2 weeks. If it's very slow tachycardia, 140 beats per minute, many patients will survive it quite long, but they will develop very severe heart failure with kidney failure and in the end multi-organ failure. And that makes me sad. I said, wow, if there would have been one simple ATP, takes 10 seconds, terminates VT, it does not come back, then this patient would survive, and otherwise sometimes they're hospitalized and die. So I think there is an important role for ATP. What is somehow not clear till today is why is it that in MEDIT-RID the delayed therapies were not as effective as the high rate only therapies. So I would have said if you apply ATP also for slow VTs, but you wait 30 seconds, 60 seconds if it will stop by itself. Then you have a beautiful therapy of these arrhythmias. However, like also Gianluca Botto told us, there's maybe a risk that some ATPs might accelerate ventricular tachycardias and may make things worse. So we have to look into that a little bit more. However, I think after Made-it-RIT, when I saw the study protocol of Made-it-RIT, I thought, hey, this is ridiculous. Patients will die. If you ignore all VT below 200 beats per minute, so 199 per beats per minute will not be treated at all. This is dangerous, and it was surprising to see it obviously isn't. So there is, I think, a clear-cut benefit if we apply the lessons we've learned. That means be careful, shocks for slow VT rates. Secondly, wait if the tachycardia stops by itself. So program funny things like 90 cycles, don't do anything before 90 cycles. I think that improves ICD therapy dramatically. However, also like Gianluca said, and I agree totally with him, this has to be individualized, because after the new ICD programming recommendations came out, there was also a paper from Denmark about all the patients who died because VT below the detection rate occurred and was not detected, was not treated. So we have today to try again to individualize our treatments, take all the basic rules into account, no shocks for slow VT, wait as long as possible, but then look which patient might rather develop slow VTs, so don't ignore it completely. Which patient might have a problem with ATP, so maybe skip it or program it differently.
Okay, thank you. It was really clear. Thank you for your time, and enjoy your days in Turin. So thanks.
Thank you very much. Thanks for your questions.
Thanks.